Dr. Rohit Menon is an assistant professor of emergency medicine at University of Maryland School of Medicine. His academic interests include cardiovascular emergencies. He will be presenting next with When the Beat Drops, Pacemaker Emergencies in the Aging Heart.
Thank you so much for having me. It's a pleasure to be here. Today we're going to be talking about some PACER and AICD emergencies. Let's go ahead and get started. We have an 85-year-old male who comes in distress. They're having chest pain, shortness of breath, pre-syncope. They have a standard history except for one fact. They have sinus node dysfunction and they just got a pacemaker placed 5 days ago. What are you most worried about? Well, with pacers, there's so many things. Pneumothorax, bleeding, infection, electrical issues. The purpose of this talk is to provide you a structured emergency department approach to evaluate common subacute PACER and ICD emergencies following a recent device implantation. Subacute meaning approximately days 1 through 30. And I have a mnemonic for you. It's called PACE: pocket, access, cardiac, and electrical. Let's get started with some epidemiology first. The elderly patient. They have structural and electrical remodeling of their cardiac tissue, and that increases the prevalence of cardiac disease. Thus, they also may be more at risk for having symptomatic bradycardia, whether that be sinus node dysfunction or AV blockade. Now, as it turns out, for pacemaker indications, AV block and sinus node dysfunction are two of the major indications, especially when you have symptomatic bradycardia. There are a few others: carotid sinus disease, infiltrative disease. Maybe our patients may have had an MI. Maybe they have atrial fibrillation with symptomatic bradycardia or pauses. Maybe they have neuromuscular disease with any kind of AV block. These are all indications for pacemakers. So let's talk about the anatomy of the pacemaker. It's really just two components: the pulse generator, or the battery, and the leads, or the wires that go inside the chambers of the heart. We're probably familiar with the single chamber pacemaker. That is, a lead that goes into the RV, just like we would if we were placing a transvenous pacer or temp pacer. There are also dual chamber pacemakers as well as biventricular pacemakers. Here's an example of a dual chamber pacemaker. Not only does the wire go into the right ventricle, but it also goes into the right atrium as well. Here's an example of a biventricular pacemaker, where you have the atrial and ventricular leads on the right, but also a lead that buries into the coronary sinus and allows the left ventricle to pace as well. Make special note the area of access. A majority of these are subclavian vein access, which will come up in future slides. So on to our PACE mnemonic. Let's go ahead and get started with the pocket. What is the pocket? The pocket is where the pulse generator or the battery resides. And you can have a bunch of complications with the pocket. Really, it's bleeding and infection. You can have a pocket hematoma, you can have overlying cellulitis, deeper space infection, a pocket infection, or even deeper, endocarditis of the leads. Let's go ahead and discuss this 65-plus-year-old male who I saw who had just had an AICD placed 2 weeks ago. He presents with 2 days of chest swelling and bleeding from the site. Now, when I saw this for the first time, I was really worried. I had no idea what I was looking at. If you can picture, this is his left clavicle with the pacemaker site, but it's engorged, swollen, tender, and bloody. This is what's called a pocket hematoma. Fortunately, we can manage these conservatively. We don't need to CTA these, and the treatment's pretty simple. It's just a pressure dressing. We admitted the patient because his hemoglobin was low. He was observed and then later discharged. Now, what's a pressure dressing? Well, there are commercially available ones that you could ask your friendly neighborhood cardiologist, but if you don't have access to that, just take some gauze and compressive tape and make sure that you can really squish down that hematoma and it will reabsorb. Rarely is reversal ever needed, but anticoagulation should be paused. Now, this will be a big discussion between the patient and their cardiologist. Of course, if the bleeding is persistent despite an observation period, maybe they come in again after being discharged with increased bleeding, then they may need a hematoma evacuation. If the pocket hematoma is not addressed, it can really tense up that skin, causing skin breakdown, local infection, or deeper space infection as well. Which is a good segue to our next point, pacemaker infections. The incidence overall is around 2 to 3%, and this usually, if it does happen, will occur in the first 6 months after placement. It can be subacute, again, that under 30-day period, and patients with AICDs are at higher risk for the infections compared to those with just standard pacer leads. These are some examples of pacemaker pocket infections. We can see in our first figure, there's a little bit of erythema and swelling at the site. This is actually a patient that had a pacemaker placed just 2 weeks prior. Now, these can go more advanced. You can have erosion of the skin. You can have purulent discharge buildup as well. We can take a look at a couple other examples. Some of these are pretty subtle, others not so much. We can see here just a little bit of erythema. This is a developing pocket infection. It can be very subtle as just as tenderness and erythema. Of course, if the device is tenting the skin, that's an impending perforation. You raise your suspicion for pocket infections if there's purulent swelling, and of course, if the device is kind of peeking out, that should raise alarm bells as well. These are all erosions, fistulas, and protruding devices. Now, all of these infections can progress to deeper space infections or lead endocarditis. And unfortunately, when patients present with lead endocarditis, it's really hard to tell from other systemic infections. Their only symptom might just be a fever. However, over half of them do have some sort of local inflammation or tenderness at the pocket site as well. If a patient does get a deep space infection of their entire device, that whole device, all the leads need to be removed, and the patient needs to be placed on long-term IV antibiotics as well. We already talked about pocket, now we can go on to access. Remember that this is primarily a subclavian approach, and thus it has all the complications of a subclavian access. Pneumothorax, hemothorax, possible AV fistulas if there's arterial puncture, even thrombus, including SVC syndrome, albeit the last two are a little bit more rare. I want us to focus primarily on pneumothorax, but acknowledge that hemothorax can also be present, and we'll see an example of that later. For now, let's talk about the patient that I had, 75-year-old plus female who was discharged just 8 hours after an AICD placement. Now, she turned right around and came back to our ED at night with a little bit of hypoxia, around 88%, and I'll never forget her complaint. It was a little chest pressure, but also trouble swallowing. And this was the chest x-ray she had earlier in the day. At noon, everything looked perfect. The device looks in place, no pneumothorax, no major effusion, nothing really. But by 11 p.m., we can see that a large pneumothorax had developed, and there seems to be some tension as well. Now, fortunately, the pneumothorax complication rate is a bit lower, 0.6 to 1.6%. And that was actually based on studies in the last decade. Now, with increasing use of fluoroscopy for access as well as ultrasound, this is even lower. Patient symptoms did resolve with chest tube placement, fortunately, but this is a reminder that just because a chest x-ray was obtained earlier in the day does not rule out your current patient's possibility of having a pneumothorax. So always follow up any pacer-related complaint with a chest x-ray. Now on to cardiac complications. There is one major one. So I had an 80-year-old male who had a pacemaker placement 3 days prior, and he came in with 2 days of shortness of breath. Now, mind you, this was actually a few months after the tension pneumo patient. So when it rains, it pours. I noticed that the patient was hypotensive, tachycardic, tachypnic, hypoxic, and I had the x-ray techs come running down trying to get that x-ray to just make sure that this was an tension pneumo. But the x-ray was completely normal. So fortunately, I did have my handy dandy POCUS right there, and this is what I ended up seeing. You can see a pericardial effusion and even some RV collapse, and we can go back and just appreciate that RV diastolic collapse as well. There was also a plethoric IVC, and sure enough, this was tamponade. I did make sure to look at the prior echoes where I did not appreciate any effusion. So this is approximately a 0.5% incidence. That patient went on to get a pericardiocentesis, 400 cc's out, resolution of symptoms, as well as a drain and monitoring for a few days. Now, tamponade can occur with little lacerations of small veins or really even the myocardium, but a full-on lead perforation is quite different. These are very rare. We're unlikely to see them. They're usually caught intra-op because symptoms develop very quickly. But there are actually case reports where there are subacute presentations of these. And of course, these need cardiac surgery. This is something that you might see. So there's RV perforations, but there's also septal perforations of the lead. This is a CT where you can see the lead going through the RV and a little bit of the septum as well. You can even appreciate on the chest x-ray how the lead is completely extracardiac, and on this there is a little bit of an effusion that's presumably a little bit of hemothorax as well. Now, on to our last part of the mnemonic, our electrical complications, or what I like to just broadly call pacer malfunction. There's 3 buckets that I think of: output failure, failure to capture, and pacemaker-associated dysrhythmias. For any patient that comes in, especially if they've had a recent device placement, pacer or AICD, and there's a possibility that there's a complication, you should always get an EKG, a chest x-ray. You have to interrogate the device. This will tell you if the battery life is prematurely low, if there's any programming errors. Your cardiologist will appreciate you for that. Make sure to get electrolytes, as hyperkalemia can precipitate bradyarrhythmias, and get a cardiology consult as well. Your EKG, you'll usually see some form of inappropriate pacing, unusual bradycardia, or maybe inappropriate tachycardia. Now, output failure is the pacemaker just not pacing at all. There are no spikes where spikes should be. This may be present with pauses or bradycardia as well. Let's look at an example of this. Well, you may not even believe me if I tell you that this patient had a pacemaker. This patient is in a bradycardic rhythm. Not just that, they're in heart block. This is an example of a pacemaker that has completely had output failure from a battery gone awry. Here's another example. This is an atrial paced rhythm. You can see that when it's functioning, there's spikes before the P wave. So we see 2 or actually 3 beats where there's a spike before that P wave, but then there's many beats and pauses where there's output failure. Failure to capture is a little bit different. There are pacer spikes, but no response at all. So a spike without any QRS complex after it, to oversimplify it. This is a fantastic EKG by Dr. Mackenzie Brown. Thank you again for this. And this is quite terrifying, actually. Significant failure to capture where the pacemaker is trying. You can see all of the spikes with very little response. Pacemaker failures can come in all shapes and sizes through a large differential. Multiple cardiac causes as well as non-cardiac causes. But remember, we're trying to focus on the subacute causes, and the majority of these have to do with either some sort of lead dislodgement or premature failure of the device. Here's an extreme example of lead dislodgement. When patients first get their pacemaker, they might want to massage the area a little bit. And if you do that enough in quite a circular motion, you might actually yank the leads right out. Now, this again is an extreme example, but this is what's called Twiddler's syndrome, where the leads were in and then they got wound up and got pulled out. Of course, if any of these patients, even the failure to capture patient comes in, they're hemodynamically unstable, you need to stabilize them, and that may be with transcutaneous pacing. I do want to give one more example of a pacer dysrhythmia. What do we see here? Well, we see every single beat is paced, but it's at a rate that's around 100 to 150. It's quite fast. And this is an example of pacemaker-mediated tachycardia. Now, this is a little bit rare, but if you can imagine that a heart seeing these leads for the first time, the leads possibly irritate the myocardium and send out a PVC, well, that PVC can go up the conduction system and go retrograde, trigger an atrial beat, and then create a feed-forward cycle, an endless tachycardic loop, which then results in pacemaker-mediated tachycardia. So how do you stop it? Well, you have to break the cycle. You have to make sure that the pacemaker cannot sense that PVC or concurrent atrial beat. And the way you do that is with a magnet. This will terminate the cycle. So we've talked about so much content today, and I appreciate your attention. Just to wrap up a few points. When evaluating a pocket, always check for bleeding or infection. When thinking about access-related complications, make sure you're not missing a pneumothorax or even tamponade from a perforation. And then for electrical, make sure you consider lead displacement, pacemaker failure, and pacemaker-mediated tachycardia as well. Thank you again for your time. I very much appreciate it.